Well, welcome to the Block 1 wrap up. During this first block, we covered a vast amount of information, introducing updates to the treatment based classification system, covering aspects of medical screening, and also the lower quarter screening portion of the exam. And I just want to commend everybody for a job well done this block. I was really impressed with the quality of the posting, as well as the really clinical applicable questions that everybody was asking. So great job this week. Within this wrap up, I'm just going to highlight a few points around medical intake screening, treatment-based classification, lower quarter screening, and then finally get to just a few housekeeping items. First off, with medical screening, really the question to be asking is the patient coming to you with low back pain. Is that low back pain actually lower back pain, or is that a presentation of which might have visceral components and or with some of the more significant issues that may present? I think within the forum discussions, what really everybody was discussing and learning about and trying to wrap the head about really came to issues around efficiency with this. And this was a great block for increasing our awareness and understanding about how important this medical screening aspect is. And from an efficiency standpoint, I do think there are some questions that really probably apply to all patients that come into our clinics. And then from there, depending really what our hypothesis list is, depending on the patient profile, depending on information from the past medical history, depending on information from understanding the behavior and the character of their pain complaint, we then can delve into when we need to deeper screen for issues. But really, it all starts off with realizing that when we are going through our evaluation and examination process, that we're really working with an extensive differential hypothesis list. And that hypothesis list starts off very broad. So in other words, as a start in the process, recognizing what that visceral issues and more significant issues could be present, and then using our screening questions to decrease our concern or maybe even the patient's concern about some of these more significant issues. So really, I do feel that, we should be medically screening all patients reporting of lower back pain. I mean, that is really our job. And that is regardless of how they came into our clinics, whether they came in with or without physician referral. We really owe a quality exam, and we have a duty really to be screening appropriately. The other thing is that even in patients that are coming to us with referral, we are a part of that medical team. And, I think we have the luxury really of being able to spend some high quality time with our patients. And so we really have a role to play there. The other aspect here really is that medical screening is really ongoing over the course of care. And I just want to highlight that. That first day visit, certainly we make things some priority, but that we're considering how is this patient evolving? How are they improving? How are they progressing? And also we can explore things throughout the episode of care really relating to the topics and discussions we had around medical screening. All in all, I really appreciated that people are recognizing how important medical screening is. Many of you are already doing this in the clinics. And so I would really say that it's a question of really reflection on your quality of your practice here. And what elements do you need to improve upon really to bring your practice up to the next level? And that's certainly a question that I ask myself every time I review this material as well as the other material in the courses. We had some very good discussion around treatment-based classification as well as some of the pros and the cons. And what I want to highlight here is that, I think the treatment-based classification is often thought as really this algorithm, these defined steps to follow. And while it does serve as our guide, it really does not replace our clinical decision making. And so I think that's a very important point. It's a guide to us, but not an end-all be-all with respect to patient care. And I think that's really a pro of the treatment-based classification, in that we can use this as a very good guide, but then have the freedom to use our clinical decision-making skills really to provide top-notch, high-quality care. The other aspect to that is that there's a lot of flexibility that's inherently built into this that allows us to apply this regardless of where our underlying manual therapy or specific camp that we may be prescribing to. In other words, regardless of the school of thought, I think it's very easy to integrate that within the treatment-based classification system. And certainly that is a strength. By far and away, the biggest con that was discussed, which is well supported in the literature, is sometimes the difficulty with classification. And with respect to patients that pair, concurrently within two classifications, I just want to point out that, it can be that patients do require maybe more than one thing. And so I think that crossover is sometimes around that aspect. The other thing is that I think the progression of the patient is also an important aspect. And so, that patient comes into symptom modulation and maybe they progress more into then the functional optimization category. And so we can view this as a progression. Now, as we know that when we consider progression in the clinic, it's not always a straight upward line, and there can be some fluctuation. So I think we can use this really to prioritize what is our progression going to be, but also what is our treatment going to really consist of at the time we're seeing them. We may need to delve down into a patient that's been progressing well because they come back in with a symptom flare, and so being able to regroup and then coming into the ability to provide intervention that allow for that symptom modulation. Much of the research that's looked at the difficulty in classification really comes out of Stanton et al., JOSPT 2011. And, there's a nice follow-up article by Stanton and colleagues, JOSP 2013, which is in the additional readings folder of block 1. And they really looked at what are the characteristics of people who are unclear to classify using the TBC. And I think that's a great read for everybody. It fits what I see clinically often, in that this group that's hard to classify, perhaps they have these characteristics that are of longer standing symptoms, perhaps a little bit less severe and irritable. And so, have a look at that article. Again, it's Stanton JOSPT 2013 in the additional readings. I think that will give you some good insight. The final thing regarding the treatment-based classification, another true strength, is really that it fits very nicely within our system using the SINs. And so, as you're applying this clinically, be thinking about how these different categories, if you will, really tie into concepts of severity, irritability, nature, stage, and stability, which are certainly key aspects to us. The third topic was really over lower quarter screening, and the key point here, gang, is to get really good at doing the basics. So, this is a great chance, if this is unfamiliar to you, to really know this information and own it. And it also may be information that we need to really need to review. So have some good clinical resources at your disposal at your clinics. Feel free to print out this slide as one aspect. Having good dermatomal charts available for reference. Really practice the skills of the neurological exam. As a general rule, symptoms past the gluteal fold really require a high-quality neurological exam. Myotomal testing, dermatomal testing, reflexes, and screening for upper motor neuron signs. The other aspect of the lower quarter screen is really the need that exists when we're dealing with people of lower back pain to go into some differential between hip versus lumbar spine or even versus thoracic spine. So that is a early decision point in using our clinical skills to help differentiate that. Certainly there can be overlap, but just think about regionally differentiating aspects. And then the importance, I just want to mention, of static posture assessment. We don't need to be posture Nazis here, but posture can give us great information about sort of the state of things, quality of tissues, what we might expect to find in our exam. So, practice those skills of static posture assessment. These elements will also things that will be heavily tied into the weekend intensives. So, again, we get really good at doing the basics. A few aspects with the patient case. This case will evolve for us throughout the course, rather. So in this block, we're presenting a medical intake form, and I think everybody had some pretty good consensus over items which they had some concerns, and that is exactly the point. The point here is to use these intake forms, your pre-evaluation screening, and really start to get a picture of what questions you would want to further ask the patient to gain further information or gain further insight. And I thought everybody did a fantastic job within the discussion forums of doing that. Brief housekeeping points, gang. When you're composing your posts, and most of you are doing a great job of this, we're trying to minimize summary really and get you to reflect and synthesize the information. Please read your posts, and we certainly encourage integration of outside references, including references within your post. Continue to do the excellent job of referencing presentation or covered material, and you can certainly post these articles directly into Moodle. Don't be afraid to offer your professional opinion. This is our level 5 evidence. It does build post strength. And so just continue to do the great job that all of you are doing about really reflecting on this information and how does it relate really practically to what you're seeing in the clinic, and what are the areas of things that you're doing well and areas that you need further growth. It's been fantastic to work with everybody this week, and I very much look forward to moving on to Block 2. As we move on to Block 2, please review the course syllabus and Block 2 instructions. We'll be dealing with manipulation and specific exercises. Keep up the good work of being really good with timeliness and attentive to details. Fitz, I've added a few notes for you, but please feel to reach out to me with any questions. Thanks, gang, and have a great rest of your weekend. It has been a pleasure to work with you.